particularly love this doctor because sorry Brett, I have to throw my husband under the bus. We got to visit him, and I will tell you that you heard my story earlier. Our first in vitro that did not come to fruition. We then sought treatment through him. And you even said, we don't know if that made a difference in our second in vitro or not, but certainly didn't hurt. And so after we had some treatments with him, we did have a successful IVF cycle. So I can't thank him enough for what he did for us. So anyway, and for the men in the room, I know this is probably a little bit of an uncomfortable topic, but we do appreciate you guys being here. And then for that, here's Dr. Nadia.
My name is Ajanenko, as Tammy said. I am Associate Professor of Urology at KU and have the pleasure to talk to you today. And before I start talking, let's sort the accent out. Right? I'm from England. I trained in London, so I've got this funny degree after my name. That is an MD degree, which stands for Bachelor of Medicine, Bachelor of Surgery. I emigrated and was at Yale for a couple of years, and then at the University of Pittsburgh to do my training in the US, and already been trained in England, and also then went to Cleveland Clinic to do my male reproduction fellowship, which is a microsurgery and male infertility fellowship. And then I've now been in practice for 13 years, 6 of which have been here at KU. And I feel very passionately to talk to you guys in the audience, and wish it would board, about the aspect of male evaluation, right? It's often overlooked. Thankfully nowadays it's becoming much more a topic of discussion. It's not an admission of guilt on the male side, just like it isn't an admission of guilt on the women's side. They have any issues. It's a couple's problem, and I want to make sure everybody, whoever hears this talk, understands that you're a team. And unfortunately, I also have, and unfortunately or unfortunately, have enough personal experience, because my wife and I had infertility when I was a resident. And so therefore, like many of the stories you've heard today, I was blessed to be in a position to give forward and help others. And it became a true passion and a mission in my own life and my career, which is why I do this basically, and I will do throughout that. And in that light, we have 4 lovely children. Yes, 4. But they came in 2 lots. We had a singleton, and then we had triplets. And yeah, so Maya's right. I'm still figuring that one out. They're 12, and my oldest is 15. As a man, I feel myself having to tell you there was no obvious male factor, but that's purely and simply because my own maleness is telling me the same thing. But it doesn't matter. It's a couple's problem. And so what I'm going to talk to you all as a couple, I'm not going to look at the guys deliberately because that's not what you're here for, is to talk to you all together, is why and what is the male evaluation. I deliberately left this as a medical talk, not because I wanted to use an old talk I had, but I wanted to not talk down to you. I want you to see what I see in the literature and what's out there and what the current guidelines are in the literature and how we can help you. Okay? So that all being said, let's get going. So, first of all, this is the guidelines that was created by the American Urological Association with a panel, and I'm humbled to say I was on it. So this is what I'm basing a lot of this practice of explaining the procedures and the work on. This is what I've alluded to earlier at the beginning of my talk, is that the American definition of infertility is the inability to achieve pregnancy naturally within a year. Now, there's a lot of couples. You've seen them. It's a support group. This whole meeting is a support group. You're not alone. 15% of couples have infertility. It's quite a lot of people. Now, when you look at it as a male or a female distribution, clearly you can see that it's really about 50-50. Males contribute to infertility in 50% of the cases, either alone as the only way that we define the infertility, or in conjunction with a female factor. And so clearly, it's very prudent that when you see a gynecologist, you ask, well, shouldn't we be doing a semen analysis? And should we be checked out and know about what other things we can do to improve the quality, like Tammy was saying, that we can make things better, not only for natural, but for IVF and IUI. You need to to make the whole process a team effort to make the process work for you. It has to be in your favor. The end game is a baby, and that's for you. Now, that's why I do a male evaluation. Why? And if you look at the actual things I've underlined, see if there's something reversible. Maybe I can tweak it and you can get pregnant naturally and you don't need doctors in your life anymore. Maybe we can maximize the quality versus reproductive technology. But most of all, the third thing, this is the thing I think about most of all when I see the male patients. I'm a men's health specialist, right? You as females go to the gynecologist for your women's health and your primary care doctors. I am that guy, or another urologist, is that person who is trying to be the male advocate about improving life and health issues that might be life-threatening, or certainly like diabetes, for example. Sometimes I'm the first person to make that diagnosis. I'm a plumber. That's what I'm saying. But the point is that you detect things that are reversible. Can I use the word plumber?
It's not the other ones I told you not.
All right. I've been quarantined for the words I've been using.
You'll thank me later.
Yeah, you will thank me later. But also detection of genetic conditions. And I will tell you a story, because this is one, again, near and dear to my heart. A 16-year-old man felt to be an alcoholic. Okay? Delinquent, been in and out of juvie, comes in at the age of 24, has no sperm, tells me his story. I found out he had cystic fibrosis. He had been labelled for most of his youth as a delinquent because he drank a little bit out, under the age of 21, and he got wicked pancreatitis. Nothing to do with it. He had a genetic disorder. I've never seen a man cry more in my office than that day. Right? So these are the things that matter. All right? This is why I do what I do. And this is what I am. And this is what gynecologists are in any way. Is I think of things on the sperm level and even smaller than that on molecular level. Right? That's DNA. I do microsurgery. That's what I do because that's what the anatomy in terms of the ducts are very small. I'm a men's health specialist. I'm an endocrinologist, meaning the hormones, and a geneticist by default, none of which I'm, of course, board certified in, but I have, because of my specialty, become experienced in that. Sex counselor. You will know that that's becoming an issue more and more about your relationship itself and how that may play a role in your fertility. Psychologist. We're all lay psychologists, and of course you need a real psychologist to be around helping. And an ethicist, because there are some important decision makers in your discussion, especially genetic, whether you should go forward or not. Right? Green light, red light, I call it. And I'm a pseudo-gynecologist, thanks to people like Dr. Creed and others who have given me my own education in their business. And of course, finally and sadly, you know that one, the last one, financial advisor. Why? Because we know this stuff comes out of your own pocket, it's not covered by insurance, and we need to understand and respect what it costs you. So that's what we do. That's what we do. Of course, what do we look out for? Just like any evaluation, whether you do it with a gynecologist's office or in a male reproduction specialist, is we need to know how often you have sex, timing, duration of the problem, childhood illnesses and development history, all of the classic things that have red flags in our evaluation, medical conditions, prior surgeries, of course if you've ever had erectile dysfunction, sexually transmitted infections, toxin and lifestyle exposure, you heard that a little bit in the other breakout session, smoking, classic, worst. Okay, please, you have to try to stop. Toxins can be, including these plastic bottles, by the way, just to add insult to you. Bisphosphonates, phthalates, you've heard it, with microwave plastic, not good, right? All this stuff leaches into the water. From the day we're born and have an IUD in our arm and we're a baby or something of that nature, you're getting these things that actually are toxic to sperm. And we found that sperm counts are declining with generations. And so, whether it be that, whether it be carbon monoxide and all that other stuff. Medications play a big role. Some of the things you don't even think about. I was about to say one that no longer is used, but that's heartburn medication that's not used as much. But there are others. Medications for blood pressure, medications for even antibiotics can play a role. Of course, it's very important for me, just like it is for the female evaluation. I need to be aware of what's going on the female side. The cycles regular, have they had IUDs, have they had any issues growing up with gynecological? There are, of course, age issues that I need to be respectful of on the female side to make sure that I don't keep doing this academic workup for the sake of it, just so that I can, feel like I'm making the male side better when time is ticking on the other side, potentially. So you have to be respectful of that. Family history does matter, especially things like testicular cancer and other previous reproductive problems, even in the men. So, now, right, what did I tell you about toxins in the environment? Okay, I'm trying to make this light-hearted as well. Otherwise I won't keep your attention for more than 5 minutes, alright? Alright? This was me at college, this is me now. Except the anatomy down there, maybe. Obviously biology. Health issues in men with infertility. Alright? This is what I'm talking about. This is a paper written by a friend of mine out of Alabama, University of Alabama, that showed that 6% of men who see for infertility have other problems, including testicular cancer, prostate cancer, diabetes, and low thyroid issues. But a lot of them have genetic disorders. Okay? So like I said at the beginning, it's surprising how often it actually is there and lurking underneath the semen analysis. Alright? This is, like I said, sometimes the first time a man's evaluated, and I'm okay with that. I work with the CDC, I work on a public awareness campaign many times, because I want men in this buzz right now with a lot of the testosterone thing that's out there, and Viagra's of the world. You know, that's okay. Men need to be evaluated because they think they're indestructible till the age of 40, and they're not. They are often still vulnerable, but not willing to admit it. Okay, so that's the first barrier we have to overcome. And because a female partner makes it. Let's be honest, okay? Let's be honest, guys. You know we're only doing it because sometimes, initially, you know, it's not coming. You go get checked. I'll go sometime. All right. I know that. I'm married. I know. Every day. I go to the doctor. I go to the doctor 5 days. Right. Yeah, exactly. Physical exam. Now, this is where it's important. Reproductive gynecologists are awesome because they are very attuned to the male side as well. Some of them will do the male evaluation fine, and they do the physical exam. Remember, I do this 30 times a day. I examine the guys, and I know the subtleties of what I'm feeling potentially. Odd specialty, I admit that, but nevertheless, I do know exactly what I'm doing. Where testicular size is very important, believe it or not. And again, you guys, many times, no guys know what another guy really, generally examines another man. And don't know what this normal definition is of testis size. And why does it even matter? It's not bravado, it's whatever. It's to do with sperm, right? 80% of the testicle is involved in making sperm. So when there's actually very small, there's subtle changes, there's obvious changes in size, those things correlate with problems with sperm production. It's not rocket science. I am a plumber, and I behave like that sometimes. That I try to think of things very simply in my own mind, so that I can convey this to all of you. Alright? You feel the epididymis. There's the sperm duct behind the testicle. That's what a lot of the processing of sperm occurs, whether it's thick, whether it's soft, whether it's missing, believe it or not, congenitally. And sometimes, again, the vas deferens, the thing that guys get a vasectomy done on, can be missing. And I've now done this week, we just actually treated 3 couples who had a male partner who had missing vas deferens. Varicocele, these are these veins that are actually normal anatomy in men, but they can become bigger, and it's kind of a problem with heat, kind of a radiator thing, not getting rid of the heat very well. Of course, as I said, it's very important sometimes when a man walks in the door to do all the other stuff. Listen to their heart, maybe they've got a murmur, listen to make sure they don't have breast tenderness or masses, God forbid that they do. But breast exam is surprisingly not done in many other clinics, and that sometimes is important to discuss. Rectal exam, that's what DRE means, rectal exam. Only if necessary, based on the semen volume or age of the male partner, and as I am seeing men older and older who are still having children. Again, the definition of when are they in their reproductive years is when you guys tell us you're not having children, right? Otherwise, you're always in the reproductive years, all right? So that's why when men are evaluated, I'm evaluated everyone to the age of 66, and maybe even a little bit older. But we have a different conversation there about genetic risks and all the other things. So these are the things which we sometimes do. Listening to the heart, and sometimes the heart's on the wrong side. Very rarely, but it can be. It has very much an association, believe it or not, with the sperm, right? Because that can be an effect on the motility or swimming ability of the sperm. Now this is important, but this is more for you to be empowered, more than it is for you to remember anything. there are new guidelines on the definition of a normal seeding analysis, right? If we're going to use lab tests, guess what? We have to know the reference rate. We have to know what we're talking about. Are we above or below it? Our whole life are all stats, right? Whether you're watching baseball, watching football, playing football, or anything, you need to have some stats about whether something's considered normal or abnormal. Well, sadly, that doesn't mean that anybody with lower than these numbers is abnormal. All it means is that it potentially could be problems with the ability to achieve pregnancy. This came out in 2010, and what they said was that 95% of men who were done in this fertile group got pregnant when their numbers were equal to or higher than these numbers. Okay? That left 5% who still got pregnant under that number, so don't dismiss it. But it's also a means to explain crudely, because that's what a semen analysis really is. You have to remember that there is a tech trying to watch these things zip around and count at the same time, which is very tricky, and somebody who does it a lot knows what they're doing. And so that's why it's important never to rely on one, always to do at least two, sometimes three, with adequate abstinence, meaning not ejaculating. You need to build, and Dr. Krieg alluded to this, it is preferable to collect at home if you're not too far away from your clinic. Because there is data to show that if you collect at home, the guys, if they collect at home, obviously, aren't as embarrassed as collecting in a clinic. But also the quality tends to be better. Remember, we're in an artificial environment in the clinic. So your semen analysis can reflect that. And you want to know what is going on at the home end in terms of quality of sperm to define whether there's a problem that we can address or fix, right? So again, this is very important because, like I said, a lot of people will make referrals to a gynecologist or a urologist purely and simply on this test. And we showed that actually, sadly, only 11% of community labs that do semen analyses actually follow the correct criteria. 11%. That's just shocking to me, right? And that's why we wrote the paper, actually. And again, not to make it too seedy, but the quality of the semen is also dependent on where it is from. And not most urologists, unfortunately, not a lot of urologists even know this. But where the semen comes from is actually not from the testicles, which is where every layperson thinks it is, but it's actually mostly from the back of the prostate or the prostate itself. The seminal vesicles are behind the prostate, and from the vas deferens also. Okay, so it's important. Now, endocrine means hormonal evaluation, right? Especially if the sperm count, specifically the concentration, is under 10 million. That's right by the guidelines, right? It doesn't mean everybody needs it done. This is how you get to be cost effective in a financial way for you guys. You don't need the kitchen sink thrown at you just if you have a normal sperm count. It doesn't need to be the case. But needless to say, if you have a consistent average sperm count below 10 million per milliliter, or cc, then often it requires a hormonal evaluation, which is blood. Of course, if the man has sexual dysfunction, that's a red light. That's a red flag for me, because maybe there's something hormonally that's disrupting it. And I had a man who I saw, believe it or not, after a vasectomy reversal, who didn't do too well. We thought, oh, it might be blockage. I didn't even do the vas reversal, but I saw him for his visit. It was from a vas reversal, and his sperm count was really low to almost nothing. And then he tells me, and this is me being a homophobe right for a second, oh, I cry at Bambi movies, I do this, I'm very emotional. I'm like, okay, is this normal for you or not? He says, no, really bizarre. He had a tumor of the pituitary gland. And guess what? There was medical treatment, and his sperm count came up. All right? We wrote that one up. But needless to say, that's what we do. All right? Now, you are all savvy shoppers in this current environment, right? Medicine and cost. So you can ask the questions, why do you need that blood test? It's not unheard of. It's nothing we should be actually even defensive about. How do I need it? What do I need? What do you need to do? I had a patient just yesterday who had private pay who said, well, what tests do you absolutely need, doc? Because I'll shop around about the lab, and I'll find a lab that does it for the cheapest. And I'm like, well, that's different. I never thought about that way. So he was going to PRL or LabCorp or whoever he was going to find out the cost of something that you could even shop around online. You know, and so these are important. You have to defend why you do it. I mean, we all want to be defensive as doctors, but do the kitchen sink to save the person a visit. But ultimately, you have to ask yourself, what do I need to know? And for a man, many times it's only two hormone tests, the FSH and the testosterone. This is the brain hormone that stimulates the testicles to make sperm. They check it in women, they've moved on a little bit more in the women arena because they check AMH and inhibit a little bit more, but we should probably do that later on as we develop our tests. But often if there's a problem with these, we go on and do some other tests, which may be, but then again you have to ask yourself, is it easier for me to have somebody drive 4 hours to see me, do it all now, or drive back another time and do it locally? That's always a decision. I'm going to whiz through this, but this is just a quick description of what the brain does and how it does it with the different hormones. FSH and LH are the exact same 2 hormones that women make. It just goes to different areas in the gonads, in the guy's case, of course, the testicles, and the feedback systems, all through the blood, okay? It's just like any servo you might have, any electrical circuit you might have, it has a feedback to the brain. And that's ultimately what we're checking for. So this is the science behind what we're doing. We're just checking all of these things and how they influence the axis. I'm going to bypass that one. That was just how I interpret ups and downs on lab tests and what I could do for you in terms of experiencing, understanding the issue. Now, again, this is a little bit further on in the evaluation of a male patient, but this is how some of these decision makers are important for you, right, as a couple. A man who has no sperm, it's actually 10% or so of men who have infertility have no sperm, okay? Now you have to ask yourself, as you do when you're at home wondering about this stuff, are you blocked or is it a production problem? Okay, that's a very important one for a lot of couples. And when do you need to do a testicular biopsy? All right? And in other words, to make a diagnosis to prove that there's sperm in the testicles. And that, you don't always need to do a biopsy, which is why I get really heartbroken when I see guys who walk in and have the kitchen sink in front of them, transrectal ultrasound, scope up the penis, and they've had a biopsy, and I'm like, but I could have told you in a blood test you didn't need any of those. You think about that, guys. I know they're in the room thinking, oh my God. But think of it as a couple. You know, that's just not fair. That's not fair to anyone to go through. I don't want those things done to me. Why would I want it done to you? All right? So all it takes is a blood test that could be 2 or 3 times higher, and you don't need a biopsy. It tells you there's a production problem. Okay? So that's what I do. That's why I do it. Okay? It doesn't take enough knowledge. But anyway, when do I use some of that knowledge to change my thinking? There are a few numbers, but it doesn't matter what they are for you, but they're just to prove that, again, these are good friends of mine, especially the last 2. That blood test plus that testicular size I told you about, I get calipers out, they're not sharp, I promise you that. But you measure that and you can figure out if there's a blockage, at least statistically. Right? If you have an FSH that's low, which is good, not too low, but it's low, and your testicular size is good, based on that measurement, you have a 96% chance it could be blocked. Right? Wow. Maybe there's a role for a biopsy. And guess what? There may be a role for doing microsurgery, right? And fixing you permanently and getting you pregnant without any of us. Now, I sit with a couple and I give them the choice. Listen, if we find sperm, we'll freeze the sperm, you can do it in vitro and you can do the microsurgery. But again, cost. Is it out of pocket? Is it not out of pocket? I get insurance to pay for the microsurgery or not. And then you have to weigh costs. Right? Sadly, but true. And sometimes when people are like, just get us there, please, just get us to the baby, we don't need to wait any longer. And that's fine. I'm okay with that, just as long as we have the conversation. Sometimes we, of course, they do microsurgery, I get them, and I would say, thankfully, pregnancy rates, about 50% of the couples who have this kind of blockage in my head right now, and I'm very proud of that. And guess what? They never see another doctor have another kid, I would hope. You know, and so we get Christmas cards with their second or third child, and that's wonderful. But you know what? But like I said, that's where we're a team. We work as a team to let the couple decide. If a woman's 40, do I do a microsurgery on the guy, or do we move on in vitro? If there's a female factor that's going to rate limit me, I'm going to say, listen, time, another year, maybe you should move on to do in vitro. Okay? And these are the decision-making trees that you have to follow if you're thoughtful. And that's why I try to hopefully tell you about these things. Hypogonadism is just a long medical word for low testosterone, ultimately. Right? Now, this is my soapbox moment, and I will promise you that this is important. You've seen the ads for testosterone on TV right now. They're going crazy. They've got a lot of money. Sales have gone through the roof in the last few years. Right? Why? Because it's the new hormone replacement therapy, not for women, but for guys. Right? The problem is, and they talk about it in the very last thing when they talk really, really quickly, it will lower your sperm count. Now they've added that, they never used to. Right? 7% of my practice, maybe more now, but is due to inappropriate use of that testosterone that they put out there that people are on. 7% that was caused by medical testosterone. Right? That means that you're shutting your brain down and sperm count. It's like being on the birth control pill for men, for women. Okay? It's the same thing, it might as well be. Okay? I cannot tell you how many men walk in the door and said, oh yeah, I had a low T, I had low energy, you know, and then of course, did they ask you if you still wanted children? Well, no, I just got put on this stuff, and then here we are. I'm like, well, guess what? That's why your sperm count's 0. Let's stop it. 9 months later, yes, it could take a little while. It starts coming back. However, a proportion of those men don't come back. Right? That's another problem. But the problem there is not necessarily, oh, the medicine, it shut me down, I can't start my sperm count back up. What is it? It's because they probably had a medical condition, genetic condition, or a fertility problem before they got put on the testosterone, but they never knew it. All right? That's the big problem, is we're finding these people who are not responding to stopping the medication or being put on something to reboot them, as I call it. And then you find out, oh my goodness, that guy's got Klinefelter syndrome. And he's got extra X chromosomes, XXY instead of XY. Right? I've seen it all, and obviously I've not lived long enough to see it all, but needless to say, that's what I'm seeing. So there's the genetic testing. What do we do and when do we do it? You do it on men who have no sperm, which is AZO, or a concentration under 5 million per cc. These are just guidelines. This is the playbook, guys and women. This is what we go by. If you have no vas deferens, this is congenital bilateral absence of the vas deferens, or unilateral absence of vas deferens, then you need to do cystic fibrosis testing. That's a big one. That one's probably the biggest one in my life. Because 1 in 25 to 1 in 50 Caucasian people carry the cystic fibrosis gene, of which there's about 1,000 of them. So a man has that risk because, guess what? They took cystic fibrosis guys, examined them. Hey, you're missing the vas deferens on both sides. Well, then you find guys who don't have cystic fibrosis are missing the vas deferens. Guess what? 80% of them will have cystic fibrosis on their genes, on their chromosomes. 80%. Right? Probably more than that. We just can't test it all for the other 20%. So that's why the wife needs to be tested, right? I mean, this is why it's a couple's problem. You can't make this decision with one blinkered look. So that's why the wife needs to be evaluated. If she's carrying the gene, that's where the ethical thing comes into play, right? If a wife is a carrier and you know that the guy probably carries this, it's a 1 in 2 or 1 in 4 chance that they're going to end up with a kid with cystic fibrosis. You can't sleep at night if you knew that as a doctor, right? I would personally take my morals a little bit further than ethics and say, I don't want to do this if you're not going to consider the risk. Because guess what? If you've ever unfortunately seen someone with cystic fibrosis, it can be a life-threatening, life-shortening lung condition that they suffer with respiratory infections and terrible situations very early on. So please, 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 this is why I exist. Now, another criteria that sometimes crops up, the low semen volume. I think, oh my goodness, it's a problem, and what do we do about it? First thing, I'm a plumber, I'm a pretty straightforward guy. You know, maybe you missed the container. Alright, how about that? Alright, I didn't have the degree for that one. Maybe you didn't wait long enough. How about that? Alright, yes, you will complete your storage if you don't wait long enough. Maybe you're backfiring, that's what retrograde means, goes into the black, that's why there's a urine container over there. Alright, and maybe there's a problem with the process neurological, meaning the nerves, that leads to transfer of sperm from the testicles into the ejaculate, right? Spinal cord patients, classic example, right? But there are psychogenic people, meaning psychological reasons why men can't do it as well. Sometimes men can't masturbate. Then there's a relatively rare condition where there's a cyst in the prostate, which they think embryologically, believe it or not, is a remnant when we were one sex and then we split into male or female, and that used to be what made it become a vagina. But the prostate didn't get rid of it, and hence it blocks the ducts, and that can happen in the low volume. Congenital absence of the vas deferens, because it's not the only thing that's missing when that happens. They're missing part of the epididymis, that sperm duct behind the testicle. They're missing the vas deferens. They're missing those ducts behind the prostate. Remember that pie chart I showed you? Most of the fluid comes from that seminal vesicles that could be missing. And guess what? 10% of men could also be missing a kidney. Wait a minute, hold on. He's talking about this stuff, and he's talking about now out here. Yes, I'm missing a kidney. Now, most guys, by the time they're trying to have kids, have got past the baseball stage, the football stage, the martial arts stage, and the ultimate fighter type stage of their life. They're not going to get kicked in the kidneys. But think about it, every one of you. If you got in a car accident, seatbelt, whatever, and you only had one kidney, and you had a renal trauma, guess what? Or even you get a kidney stone. Wouldn't you like to know that you wore a wristband, or your spouse, or your loved one said, he only has one kidney? No? Right? Not rocket. Alright, but now they said if you have any sperm in the urine after you ejaculate, it's a positive test and it could be backfiring. Well, there could be some in the urethra, the pee tube, but I'm not sure if that's complete. That's the going on. Okay. Transrectal ultrasound. Don't get one unless you need one. Right? That's the message of the day. And when do you need it? Not very often. You only need it often when the sperm count is 0 and the semen volume is low. All right? I took that semen analysis and I made a huge evaluation to save that unpleasant situation. All right? This is a prostate exam. There's that cyst I was telling you about. All right? This is what that cyst looks like if you injected dye into it. Now, you don't know that. That could be a vagina. You wouldn't know that was male or female. It's over there. But that's the point, is that congenitally you can have an issue that an acid pH and a low semen volume will actually totally tell me why I need to do that. And I have to justify it to the guys. Yes, this is why. Not because you're just letting me. Alright? Scrotal ultrasound. When do you need it? Not actually that often. Not that often, actually. But you can't quite tell over here, but this is the testicle here. And if you know, this is all kind of the same, it's got little sparkles in it, little white dots in it, that's microcalcification. But what's not normal? Alright? You don't need to do it very often, but when do you need to do it? Ambiguous finding on an exam, sometimes you need to get a better, accurate measurement of testicular size, especially young men, when we're trying to figure out whether they have a variance or whether to fix it or not. Difficult exam, of course. So you don't do it just because you feel the veins. You don't need to, that's not indicated. But of course, if you have things like you have a testicular cancer on the other side, men who've had undescended testicles that were brought down, where there's a slightly increased risk of tumours later on in life, there's actually a 40 times increased risk of tumour if you had an undescended testicle. But it doesn't matter when you had it brought down in your life. So those are sometimes, I put them in parentheses, purely because it's a soft call. You have to decide whether the physical exam actually warrants it. And that, wow, well, actually before, I suppose that's amazing. Thank you very much. On that note, and again, this is not an admission of eligibility or anything, please ask any questions. Just because you're asking doesn't tell me. Please, that's why I wanted the extra few minutes, is just to give you the opportunity to ask questions publicly, of course, or if you want to catch me in a few minutes privately, please do. Are there any generic questions about the birds and the bees that you need answered? Any thoughts? Yes?
So, would you recommend before doing IUI or IVF? Like my husband has just had the basic testing and they found it low. He's not here. He doesn't know I'm saying this. But do you think he should come to you before we invest?
Any urologist, yeah, especially, just because I specialise in it, absolutely, I'd say that. I'm not putting an advert, but just because that's what I do. But, yes, again, pardon my French, but a semen analysis is the lightning rod to a lot of other things. It tells you about other things that leads to these workups, right? If it's consistently low, first of all, let's think of it pragmatically for you. That's going to affect the ability to do IUI. Well, you need to do IUI, you need to do IVF. Well, if you're going to cough up the big difference in price, surely you need to know, can we make it better? Maybe we can take it from IVF to IUI. and if not, what can we do? And so I haven't talked about some of the really simple things that Tammy briefly touched upon at the beginning when she introduced me. What can I do empirically? I mean, there are so many little things that you don't realise. Smoking, classic, right? Stop. Drinking, it takes a lot to drink before you start drinking. And what I tell all my guys and all the couples I have when they see me is, anything that makes you hurt is bad for you. So when you have a hangover, guys and gals, that's bad. When your muscles are aching, your muscles are breaking down. It's bad for you. And the little swimmers down there are then hurting too, okay? I said swimmers, is that enough? Please, that okay? But so therefore, things like vitamins, right? I'm a big proponent. My research is actually on vitamin D, but I came from a big clinic which is huge on a reactive oxygen species, which is antioxidants. I'll give you my free consult right here. So your vitamins are A through E, not rocket science again. A, B, C, D, E. Simple. E is very important, it's an antioxidant. C is very important, it's an antioxidant. D is important more and more because they found that vitamin D is on sperm. That was our research, frankly. But needless to say, they showed vitamin D. We're all vitamin depleted nowadays, right? Everyone seems to think that. Right, B. B is involved in DNA. It's the second messenger for DNA formation. A is involved in making sperm, it's retinoic acid. Okay, so then there's one more. F. There's no vitamin F. All right, just right. Folic acid. I am a huge believer in folic acid. Methylation of sperm, not to get molecular, but is a problem. Okay, it's a problem that leads to problems with pregnancy, maintaining a pregnancy, and even the next generation. Okay, so folic acid is the building block for DNA, right? Which needs vitamin B to help move in. So Metanex is the thing I've been talking about a lot recently. It's the only one that's used for diabetic neuropathy, but it's off-label for what I'm saying. Is that it's the means to give you the guys the building blocks to make things better. Okay, and so these are simple things: A, B, C, D, E, F. Right? Not rocket science. So then, the next thing is lubricants. No lubricants, there's only one on the market, they don't have shares in it, Pre-C. The only one on the market that has been shown not to kill sperm. Right? KY jelly does, all of the other ones, Astroglide, Replens, anything, they all kill sperm. Saliva has amylase in it, which will kill sperm. So, can't use that. Boxers or briefs? I'm glad you asked this question. Boxers or briefs, right? I'm just going to ask for a show of hands, because I love this. Who thinks it matters that you have to wear boxers? Not as many, because you know that was a loaded question. That's why none of you are putting your hand up. I know that, because it makes no difference. Right? However, if you really want to get kinky and wear super, super tight underwear, spandex, and really, really tight, and wear a lot, and be a sumo wrestler, yeah, I guess it matters. Right? But your regular tidy whities or boxer briefs makes no difference. Okay? It doesn't make any difference. Okay, that's a classic. So those are the toxins classically. But yes, I think anyone who has an abnormal semen analysis, and arguably we talk about this, Sasha and I, about what if a man's semen analysis is normal? Does that require an evaluation from a male specialist? Not necessarily. I think that that's important only, again, if someone like a gynecologist has had an honest conversation with the couple about lifestyle issues, you know, modifications, things like that. Smoking, again, classically, you could have a normal sperm count. But if you're smoking, it could be the problem. Okay? Obesity, you know, I'm not going to deny I'm a bit heavy. So the fact is, yes, it can affect sperm counts. Why? Because it affects the hormone parameters. Okay? So lifestyle matters in women because of the ovulation, and it very much matters in men for the same reason. Sorry, so that answers your question. Sorry.
Have you ever seen in men a lower sperm count due to severe allergies that they've had their entire life and medications they were taking?
Definitely medications, depends. Classic one, steroids. Right? The longer you're on steroids, the more it will affect the sperm count. Antihistamines, usually less of a concern per se, but it can do. I mean, again, remember, when we get that semen analysis when you guys are getting worked up, it's a reflection potentially for years of life, right? I mean, it's like women in the situation. But the difference in men is, unlike women, well, at least for face value, is that men are always reproducing every 69 days, their sperm. So if you had a cold or a really bad flu or a fever, it can reflect a semen analysis within actually less than 3 months of the next time. But if you've got a lifelong of things that have been a problem, the chronicity of a condition, like even low testosterone, which is what they're saying, right, is that low testosterone, by the way, is a reflection of probably the chronic problems we live with in life, right? Stress, diet, exercise, all of those. That's why this is so silly that we're treating the endpoint, we're not treating the actual problem. So that's an example. So someone who's had chronic illnesses maybe could have a low T, that that needs to be addressed from a clomid standpoint, by the way, many women know what that is, not testosterone. So yes, the answer is yes. It could be, I doubt it would be allergies like the anti-sperm antibodies, but it could have to put that out there as well. Any other questions? Yes.
Is there anything that they can, like eat, natural things or supplements they can take that would increase their sperm?
Not really increase. Yeah, there's no real increase. I know I wish I could find that drug, because I want basically to give it to all my patients. You know what I mean? Clomid is the one we try to use. It doesn't work very well. It's a pill. It has to be prescribed. So what else? But I have to say that generally, again, it all boils down to the same things that you've heard on TV forever. Lifestyle and diet, right? Healthier diet, healthier food, more greens, this, that. Yes, it's got to be a role with the whole total body thing, right? L-carnitine, that's all the time on the TV, not on TV, but on the internet, you Google it, you're looking for increasing sperm counts, right? Or increasing swimming ability of sperm. L-carnitine is not snake oil. What it is an antioxidant that concentrates in the epididymis behind the testicle. Okay? So it has some role. It's just how they market it, how they show data. That a lot of times in the company it's called Proxy. It's the one you can get. It's awful to taste actually, but it can make you a bit sick. But you can actually go to GNC and get it over the counter. But they sell L-acetylcarnitine. And what L-acetylcarnitine has been shown to do is, yes, in scientific data has been shown to increase sperm counts a little bit, motility a little bit, but what they couldn't prove, which they've only recently started to show a little bit, is that the pregnancies actually improve. Right? So, general lifestyle things are very important. I actually speak about mental health. I consider myself a poster child of what needs to be done, not what I've achieved. I never lie about that. I have the same stresses that you all have, all right? I've got life to lead, I've got work to do, I've got bills to pay, and guess what? Don't get time to go and exercise. And I like my burgers. so you, not too many, but that's it. Lifestyle is very important. Now, the problem is, here's what happens the other end of this. Those who do everything right, exercise, even admit they had a bad thought once in their life, and had a partner sometime in their life, and worry about did they catch an STD. No, then it becomes like Good Will Hunting, right? It's not your fault. All right? At some point you have to say, look, you can't carry the baggage of your whole life with you if there's nothing I can find. If you did have an STD, sexually transmitted infection, then yes, it could play a role, right? Yes. If you had a girlfriend that was mad at you and threw an encyclopedia at your crotch, then I'll go to it. Right? I mean, you think I was making that up? That's actually a true story. Okay? And I had research on this and put it back together. How long later? 10 years later. She had trouble, yeah, it was a different person though, thankfully. Different girlfriend, now new wife, but it was his college years, and he nailed him, and he got hurt, and he's got trauma, and he's got swollen, and he never thought anything of it. And then 10 years later, he's got no sperm, he's a new partner, and he's married, of course, and he was blocked. Right?
Well, that was my question.
He was blocked.
Blockages can be.
Based on that thing I showed you?
successful.
Yeah, exactly, that's the microsurgery. But, these are very good questions you're asking, and I wish I could talk to a bigger audience in that regard, because I want you all to know that even though, I'm a card-carrying male, I'm a card-carrying urologist, and I'm a card-carrying right now KU person, that doesn't, I'm here for everybody, is that lifestyle is very important. I'm very big about talking to the couples about men's health, because remember that slide I said, and the women makes them? You are now my disciples out there. Everybody's not here with their husband or partner. You're going to go home, and you're going to help me make them do better, right? That's what I have to do. My wife, Maggie, she's not this, what she does. She knows that. The doctor, she knows that. feed you unless you go to the doctor. All right, fine, okay. I'll get a burger. So there. Yes.
And I apologize because I've been in and out, can you tell them if you do, like, for example, if you do prescribe the Metanex as you did with Brett, how long they need to take that prior to doing the treatment?
Yeah, that's a good
I think that's
question. You know,
important.
sperm takes about 69 to 70 days to start from nothing, stem cell, to being produced and released into the ejaculate. Okay? So, kind of crudely, it's 3 months. So any change you do can take 3 months. That's why if you see me, I'll be saying 3 months. That's what I do. I always say 3 months. It's not because I want you to wait. It's just because it's a time of difference it's going to make, I hope. That's the minimum. And you hope that, like leaves on a tree, you kind of start from scratch, you give it a better environment, and you go up different paces.